Right, so I'm Gill Whitfield. I'm one of the oncologists involved in the Stereotactic Radio Surgery service, and I'm going to talk today about the place of radiotherapy for patients with brain metastases. So whole brain radiotherapy is a treatment that's been used for decades. Basically, we treat the whole brain to a uniform dose, and we do that by putting one beam in on the left and one beam on the right. So if I can work this, there's the view of the beam from one side and the beam from the other side. So we usually treat Monday to Friday over a week or over 2 weeks, 5 or 10 treatments, and basically we can do it on any standard radiotherapy machine. Very simple treatment. Stereotactic radio surgery, as it's called, which isn't any kind of surgery, it's radiotherapy, is a highly focused radiotherapy treatment which is used to treat just the brain metastases. So this is an example with the radiotherapy treatment plan on it, showing the doses that we're delivering. And each of those metastases is treated with multiple beams, in our case about 9 different beams, to give a very focused treatment. That's a much more complex radiotherapy treatment. It needs slightly specialised kit, and it's commissioned in a limited number of centres, and we've just gone through a whole UK commissioning service so that there is access for everybody. But for example, in Greater Manchester and South Lancashire, we have a centre here at Salford and at Preston to deliver those treatments. There are a number of radiotherapy platforms that are capable of doing that, and you might have heard of Gamma Knife, which is perhaps the best known SRS platform for brain treatments. In this, with this platform, typically the patient is put in a fixed head frame, and that is basically screwed into the surface of the patient's skull under local anaesthetic. When they're treated, they are moved into the treatment machine so that the lesion that we're trying to treat lies at the centre of a hemispheric dome. And basically that dome has in it around 200 apertures like this that the radiation emerges through. And that basically allows 200 beams all to be focused on that central point where the patient's tumour is. And the size of those apertures can be increased or decreased by stoppers in these holes according to the size of the tumour. And the radiation source in this is actually a radioactive source of cobalt-60, unlike the other machines, which are basically X-ray machines. So you may have heard of this machine also, the cyber knife, which again isn't any kind of knife. But this is basically a standard radiotherapy machine mounted on a robotic arm. And typically for this treatment, the patient is in a relocatable mask, that is to say, a pretty rigid moulded mask, which is custom made for them to hold them very still, but without anything needed to be screwed into their skull. And then you've got various types of relatively conventional linear accelerators. So linear accelerators, or LINACs, are the conventional radiotherapy machines that we use for all other radiotherapy. But the ones that are used for stereotactic radiosurgery are slightly specialised. So they have some additional features in their build to make them more suitable for SRS treatment, or sometimes there is bolt-on add-ons to conventional linear accelerators. So again, the patient is in a relocatable mask, a fairly rigid custom-made mask. They lie on the table, and basically we check their position before each beam is delivered using 2 orthogonal X-rays, and then we deliver a number of beams which all intersect at the tumour that we're trying to treat. And this is the machine that we have at Salford, the Novalis TX, but as I say, there are a number of different linear accelerators which are capable of doing this treatment. And although patients have often heard of the Gamma Knife, and Gamma Knife and Cyber Knife seem to sound sort of sexier, basically all these platforms are capable of the same quality of treatment, and we've just proven that through a national QA exercise for the newly commissioned services. So a little bit more detail than James has given you about how we decide about different types of treatment. So as I mentioned, the traditional treatment was whole brain radiotherapy. What evidence do we have of who benefits from this treatment? Well, actually, there isn't much very good high-level, that's to say, randomised controlled trial evidence for who benefits from this treatment, except, as I'll mention in a moment, there's a bit of evidence in lung cancer. But we know that historically, before the introduction of whole brain radiotherapy, median survival if you had brain metastases was about 2 months, and that was seen to improve after whole brain radiotherapy was introduced to maybe 3 to 5 months, which is dependent on histology. So some patients with certain tumour types, for example breast, will typically do better than other tumour types such as lung. The one really good randomised controlled trial that has been done is the Quartz trial, which was a UK trial. Yes, the only good randomised controlled trial. And this was in patients with non-small cell lung cancer with inoperable brain metastases. And they were randomised to either whole brain radiotherapy or best supportive care. And the survival was pretty dismal in both arms, 2 months, and there wasn't a significant difference whether you had the whole brain radiotherapy or not, nor was there a difference in quality of life or in steroid use. So this has put a lot of lung cancer clinicians off giving whole brain radiotherapy to many of their lung cancer patients with brain metastases. But I think it's important to say that in the Quartz trial, only a small percentage of patients were in the best prognostic group. I'm going to come back a bit to prognostic indices and what I mean by that. But I think that is true that whole brain radiotherapy doesn't help much if you're in a poor group destined to only live a couple of months. But there's a huge spectrum, and if you're the kind of patient that we know could live 1 to 2 years, then definitely you need some treatment. So we do have to get a handle on, how we decide the prognosis. Stereotactic radiosurgery, there's a little bit more evidence about who benefits from that. So there were 2 randomised controlled trials. By far the largest was the trial by Andrews in the Lancet in 2004. That's about 330 odd patients. And there was another smaller trial with about 27 patients. And those were trials for patients with up to 3 to 4 brain metastases, and they were randomised to the then standard treatment of whole brain or whole brain plus stereotactic radiosurgery. And basically, in all patients, no matter how many brain metastases, and I should say all these patients were relatively good performance status, so that means that they were self-caring, okay? So it did exclude the worst patients, and there was a limitation on the size of the metastases as well. But in all the patients in that trial, on average, adding SRS did give you better performance status 6 months down the line and less steroid use, but it didn't have a survival benefit in everybody. So survival benefit was actually again seen only in the better prognosis patients. So it was seen in patients with a solitary metastasis, and on average it's a relatively modest survival benefit, 1.5 months. All right, that's an average, of course, with some patients deriving a lot more and some patients probably not deriving any benefit. And then patients of so-called RPA class 1, and this is one of the prognostic indices I'm going to come back to. So that's to say the younger patients, they were good performance status, but with no extracranial disease. Okay, so they weren't going to die of their extracranial body disease. And in these patients, there was a couple of months survival benefit on average. And again, subsequently, there was an analysis done looking at other prognostic indices, and this is a particular prognostic index I'm also going to come back to. And again, that showed that even patients with up to 3 or 4 brain metastases, if you had a favourable prognostic classification, again, there was a survival benefit for you. Just briefly, I think James has already alluded to this, is stereotactic radiosurgery better or worse than neurosurgery? Well, there haven't been any head-to-head trials, but from the trials that there have been, we think that they're probably about equivalent. But as James has already said, neurosurgery is definitely better if there's significant mass effect. SRS is more practical if you're dealing with more than 1 metastasis, because otherwise you're putting the patient through multiple craniotomies. And SRS is usually preferable for metastases in eloquent locations where surgery might cause a neurological deficit. So these would be examples of patients who would be good for SRS. This patient, I think I already showed, with several brain metastases. This is a patient with a brain metastasis in the brainstem, 2 different views. That's not somewhere that a neurosurgeon can go and operate, but that is eminently treatable with stereotactic radiosurgery, at least for the relatively small ones. This is an example of a patient who actually we might do both things. So there's a large metastasis in the posterior fossa here. You can see it compressing the fourth ventricle. This patient is at risk of obstructive hydrocephalus, and that would be better taken out. But this second occipital lesion, that's eminently suitable for SRS. So this patient would probably go for neurosurgery first and then come back and have SRS as a subsequent treatment if their body disease overall warranted it. What about more than 4 metastases? Because the trials I mentioned earlier are for patients with up to 3 or 4 metastases. Well, there isn't any randomized evidence for patients with larger numbers of metastases, but there is now retrospective evidence from various institutions that have treated patients with more metastases. And that evidence suggests that actually the total volume of metastases is more important than the number. And most recently there was a large Japanese study published, this one by Yamamoto, and it was across a number of Japanese gamma knife centres. They looked at all patients treated with up to 10 brain metastases, but there was quite a strict limitation on volume. So that definitely wouldn't be all comers, okay? A single 3 centimetre metastasis is close to sort of 15 or so mils. So there is quite a lot of selection going on there. They may have large numbers of metastases, but they're small metastases. And they showed in this population median survival of almost 14 months if you had a solitary metastasis. But if you had 2 to 4, 10.8 months, which was the same as if you had 5 to 10. In other words, the patients with 2 to 4 and 5 to 10 did the same, provided you limited the total volume of metastases you were treating. So this has led us now to think that, you know, we should be more permissive than perhaps we've been in the past about numbers of brain metastases. And this is just to mention that in the past, treating larger numbers of metastases was relatively challenging, and we're probably only just now emerging from that era, to be quite honest. So if you treat with a gamma knife machine, the amount of time it takes in planning and in treatment goes up in direct proportion to the number of metastases. So to treat 10 metastases would actually take several hours of treatment time, never mind planning time. On a linear accelerator, if each of them is treated sequentially, which is what we do for patients with small numbers of metastases, then it's also very slow. But actually modern radiotherapy machines now let us use new techniques, things called VMAT, which is a sort of arcing technique, and that's demonstrated here. So the machine moves in an arc around the patient with a beam on all the time, and it does 5 arcs like that. And in that, it can treat all the metastases in one go. So this treatment would probably take about 30-40 minutes to treat all the metastases. So that's made it more feasible now than it was in the past. So I want to say a little bit more about life expectancy, how we look at sort of prognosis, what factors we take into account. And this is the RPA class that I've mentioned. This is quite old. This is 1997, and it was looking at patients, 1,200 patients with brain metastases from a number of trials. It divided them into 3 prognostic groups. So RPA class 1 was the younger patients, good performance status, so this means self-caring, controlled primary, no extracranial mets. So this would have been before the era of stereotactic radiosurgery, with only whole brain radiotherapy at their disposal. Patients lived a median 7 months. The worst prognostic groups are patients who weren't self-caring, 2.3 months, and everybody else somewhere in between. Okay, so that gives us a sort of initial handle how people might do. Now there have been further developments of this, also to take into account increased use of neurosurgery, increased use of stereotactic radiosurgery, and I guess it's also updated things to the modern era, 2010, which means more systemic agents, targeted agents, etc. And this graded prognostic assessment is another index derived from a large series of patients in the US, and it looked at teasing out the impact of age, the primary tumour type, what treatment they had, performance status, and number of metastases. And this can be used to predict survival. And I'm not expecting you to read this whole slide, But basically for each patient, according to their tumour type, so this would be non-small cell lung cancer and small cell, melanoma and renal, breast and gastrointestinal, you'd work out a score. So for non-small cell, it depends on your age, performance status, whether you've got extracranial metastases and number of brain metastases. For breast, interestingly, all those things aren't so important. The most important thing is your performance status. But that lets you derive a score, and that score then lets you look up what their expected survival might be. So it ranges in the worst prognostic group from a median survival of, for many groups, 3 months, but interestingly for breast, 6 months, to in the best prognostic groups, median survival of 14, 17 months, breast 18 months, and you can see there in breast that the range of survival ranges out to about 30 months, okay? So it's really important to say that, you know, although in the past we've maybe been quite negative about the outcome with brain metastases, there are patients now who are living 4, 5 years, often with breast cancer, but also with lung cancer. Patients with melanoma are now doing much better with the new immunotherapies. So there's a huge range, and these indices can help us determine who might do well. And this is the kind of information that we take into account in the neurosciences MDT. We might not always exactly calculate this score, but these are the kind of things we're taking into account in estimating whether this is a patient likely to survive more than 6 months, likely to benefit from treatment. So in deciding who gets what, the NHS only funds stereotactic radiosurgery for patients who meet these criteria. So they have to be selected by an MDT with neurosurgery, oncology and specialist SRS input. They have to be self-caring. They must have a diagnosis of cancer with either absent or controllable extracranial disease. So as James said, if the disease is progressing, they need to have some treatment options with a chance of getting that under control. They mustn't be more suitable for surgery, and there's a restriction on the total tumour volume, which obviously we have to estimate by eye looking at their scans. And they should have a reasonable life expectancy from their extracranial disease, because there's no point treating the brain if they're about to die of their body disease. So, as James already mentioned, that is discussed in a neurosciences and SRS MDT to try as a group to make the most appropriate treatment recommendation for a patient. And just to recap then, the kind of things we consider are the intracranial disease, all these factors, the extracranial disease, a number of factors, and patient-related factors. So it is quite complex decision-making, which is why we do it in the MDT. So that's the main part. Finally, a little bit of an aside, if we've got time, I think. In the initial trials, I mentioned that stereotactic radiosurgery was an add-on to whole brain radiotherapy, because whole brain radiotherapy is the traditional treatment we started with. But do we really need to give the whole brain radiotherapy still? Can we just give the SRS, or indeed just the surgery, or do we need to give the whole brain radiotherapy afterwards? Well, it's maybe worth mentioning, at the risk of offending James, that at surgery, although they may claim to take the whole metastasis out, they don't normally take a wide margin of normal tissue, such as you might do if you were taking a bowel tumour out. You take some surrounding normal bowel. We don't do that in the brain. So there is always a risk that there is at least microscopic disease, if not a bit more, left behind. SRS has the advantage that when we treat, we inevitably end up treating a small margin of normal tissue around it as the dose falls off. So you might expect that local control could be slightly better, perhaps, with stereotactic radiosurgery. And there is some randomized controlled trial evidence to help us to understand this better. So the trial by Kocher, relatively recent, randomized patients with 1 to 3 METs, good performance status, who'd had either surgery or SRS, and then they were randomized to whole brain radiotherapy or not, and they were followed up with MRI imaging. And what they showed was that with whole brain radiotherapy there was better intracranial control, less need for salvage treatments. And if we looked at the surgical group, 2 years down the line, without whole brain, 59% had relapsed at the original site. That was halved with the addition of whole brain. There were new metastases in 42%. That was halved with the addition of whole brain. In patients who'd had SRS, it was a bit less dramatic. There was less risk of having relapsed at the original site and a modest improvement with whole brain. And again, some improvement in number of new metastases. So that looks like whole brain is pretty good, doesn't it? It gets you better intracranial control. However, there was worse quality of life in some domains with whole brain, at least early on. There weren't too many patients still on follow-up at 12 months to really know what was happening at that point. It did reduce neurological deaths, but there wasn't an overall survival benefit. So although there was better intracranial control, presumably, because there was no overall survival benefit, they were still dying of their systemic disease. So that's the problem. It isn't just the brain that determines how these patients do. So what do we do? Well, locally, generally when patients have had SRS, to be honest, we don't add whole brain. When they've had surgery, usually we do add whole brain, unless there's a particular reason why they can't, such as they've had it before, or some of these factors, they've got underlying vascular disease, or perhaps if the disease is very indolent and we feel that if it recurs, it won't be too catastrophic and they'll be able to have some subsequent treatment at that point. So this is a bit debated nationally, whether you give whole brain or not after SRS or after surgery. And in any event, in the better prognosis patients, we follow them with 3 monthly MRI scans so that we can detect recurrences and offer them further treatment before they're too symptomatic. I'm nearly at the end now. Hippocampal sparing whole brain radiotherapy is a new innovation. This is a treatment which would replace standard whole brain radiotherapy. So rather than irradiating the whole brain to a uniform dose, it's all irradiated to a uniform dose except these regions on the left and right around the hippocampi, which are structures thought to be important in memory and learning. And there was a single-arm study in the US, a series of patients treated with whole brain, with hippocampal sparing whole brain radiotherapy for brain metastases, in which they showed improved neurocognitive outcomes compared to historic data. So there is in the UK now a trial ongoing, and I'm actually the chief investigator for that. It's a phase 2 randomised trial, and it's comparing whole brain versus hippocampal sparing whole brain in patients who've had aggressive treatment of their metastases, either neurosurgery or SRS. And in this area, we will probably, at least initially, mainly recruit patients who've had surgery, but practice does vary around the country, and if centres are wishing to give whole brain after SRS, then they would be able to recruit patients into this trial and offer them whole brain or hippocampal sparing whole brain. And we're hoping to demonstrate in a randomised fashion what, if any, neurocognitive benefit there is. So in conclusion, as Kath and James have both said, the management of brain metastases is quite complex, has to be individualised. I would say, despite all these newfangled techniques that we have, whole brain and best supportive care are actually still the mainstays for the majority of patients with brain metastases. But a minority are suitable for more aggressive treatments, neurosurgery, SRS, and it's really important that we consider their overall disease status. Also important to mention that patients may have some of these aggressive treatments on more than one occasion, so they might have neurosurgery and subsequently SRS, or they may have repeat SRS, and we do have patients who've had 3 SRS treatments over a period of a couple of years and have done very well with that. And some of these new radiotherapy developments may improve matters, so may make it easier for patients with larger numbers of small volume metastases to be offered aggressive treatments, or perhaps to be offered treatment which is more sparing of their neurocognition and quality of life. So that is all. Any questions?